So I'm Loïc Vasseur from the hematologic department in Saint-Louis Hospital. So the question is NGS a useful tool for stratification in TLL? So different gene alterations have been identified in TLL for quite some time. For example, NOTCH1 and FBXW7 have been shown to have a good prognostic impact in different cohorts. But there is also other genes that have an adverse impact, like TP53, DNMT3A, or P10, and that has been showed in also different cohorts. But these genes have, in most of the case, increased the risk of 10 to 20%, but it's not a black and white effect. And that's why in our group, we try to create tools to try to separate patients with different prognosis. And we did that with the results of Sanger sequencing 10 years ago, and we published this 4-gene classifier that has been externally validated in different cohorts. But in this year at ASH, we presented our work using the results of NGS, and we showed that there were also other gene alterations that were important to be taken into account to separate patients with a higher risk of relapse. But it's true that prognostic factors in TLL are quite complex to identify, and one of the important points is that we're not only looking at the aggressiveness of a disease, of the intrinsic biological factors, but also we're looking at the response to a specific therapeutic regimen. And in TLL, like in ALL in general, treatments are very heterogeneous. There is a difference in terms of which chemotherapy we are using, but also which dose, and that's especially true for asparaginase, but also what are the indication of allogeneic stem cell transplant of the CNS prophylaxis. And all these factors plays a role in which prognostic factors will be identified in our cohorts. Many studies try to address this question, but for example, in the French group, we showed that there were a difference between TLX1 and TLX3 regarding asparaginase sensitivity, and that TLX3 express more asparagine synthetase and need higher doses of asparaginase, and that impacts the effect of therapeutic regimen on these prognostic factors. There is also an interesting work of the UCAL and the FRAL group looking at the high-risk subgroup in pediatric protocols, and they show that if you intensify the chemotherapy in this patient, the risk of relapse will be lower. So that is, I think, important to take into account this NGS information. But the NGS is also very important if you're trying to use targeted therapy in TLL, and that's what we're doing at Relapse in the French group, and that was been presented by Philippe Rousselot at ASH this year. Using NGS results and a pharmaco screening, we're trying to see which subgroup of patients might benefit from targeted therapy, like, for example, patient with an alteration on IL-7 pathway benefit from JAK inhibitors, or if you have an alteration in PHF6 or PHF6 or other epigenetic regulators, you might benefit from BCL2 inhibitors. So that's also an important thing for NGS. So I would say that NGS is very important for stratification, first line in TLL, especially to adapt chemotherapy early before having all the results of MRD. But also NGS is important to try to use targeted therapy, and that's important at the moment at relapse, but that will be also very important in first-line regimen in the future. So thank you very much.